Welcome to Village in Motion. It is Wednesday, February the 20th. I am Clint Lambert. I have the privilege of being the host today for Village in Motion. And we're going to be talking about occupational therapy with Michele Ferrao, who is here in the studio with me. And Michele, welcome. Glad to have you with us.
Thank you. Happy to be here.
You've been at Green Spring, I understand, what, 10 years?
10 years.
Tremendous. And you are an occupational therapist, right?
Correct.
Okay.
And today I'm talking about occupational therapy over in the outpatient department at Hunter's Crossing and some of what we offer there.
All right. Very good. And what do you offer there? What is occupational therapy? Let me ask that to start with.
I get that question a lot. People don't really know what occupational therapists do. Occupational therapists, the word occupation is meant anything that occupies time. So we look at things that you do on a daily basis. So that might be putting on your clothing, feeding yourself, being able to take a shower, getting in and out of a shower, getting on and off a toilet, all of those things, or using your hands for a variety of things, using a keyboard, writing. So all of those things are things that occupational therapists work on, functional activities. We call them ADLs, which stands for Activities of Daily Living. In the outpatient department, we also tend to focus a lot on hand strength and coordination. And we also do some home assessments. So if somebody's new to Green Spring or somebody has had a change in their ability to walk around or something's been happening, a lot of times they'll ask us to come in and do a home safety assessment and take a look and see, can they move around their home as safely as possible? Can we recommend any equipment to make them be safer? Maybe a bed rail, maybe a commode or a toilet frame or a seat for their shower. Sometimes people have lower vision for different reasons, macular degeneration, glaucoma, and we can come in and try to help them with that as well. Can we set up the home so that it's a little bit easier for them? And toward that, a lot of what we do is recommend adaptive equipment.
Okay, and what does that mean?
That's commercially available equipment that they can purchase to help with different things that they're not being able to do.
So a walker, a rollator?
So that kind of equipment is more offered by physical therapists. They might offer that kind of thing. The kind that occupational therapy recommends is more for a functional activity, such as some of these. So we have a button hook, and so somebody who can no longer button can use something like this to slip through the button hole and pull out the button on the other side. And as you can see, it only requires a gross grip as opposed to handling with two hands. Same thing with a zipper pull. So it's got a little hook. You're having trouble pulling up your zipper. You can just kind of grab and you can put it on the zipper and pull up on that. When we were talking about the low vision, we call these little tactile dots, and we can put those sometimes like on microwave buttons. So somebody who can no longer see those numbers anymore can feel for these. They're raised dots to know where to start the microwave.
So it's kind of like reading Braille.
Kind of, except that we can customize it to a particular area that they are trying to find. So a lot of times I'll put those either on, like I said, a microwave, like a start and a stop button, or the 1 minute button, or I might put it on a dishwasher on the start button, or the same thing with the washing machine. We might try to line them up so they can see where to put it, because all of those little lines kind of tend to disappear. And it's very difficult.
They blend together.
Yes, it's very difficult to know where to situate that. In terms of hand strength, we also work with a lot of equipment in the department. Like this is for grip strength, and we work as well for finger extension strength. We have a variety of different things that
I like that. I've done the putty.
Yes.
I like that.
And the putty is a very common, these are ones we have in the department that we work with, but the putty is one we typically send home with residents that need to continue to work on grip strength or pinch strength at home as well.
You said send home. So that means that you're seeing them in the clinic.
Correct.
Doing some therapy with them.
Yes.
What kind of things can we expect if I was to go in for occupational therapy? what would I do? I mean, I have a wrist, if you noticed this morning.
And that's a common thing we treat people for. We treat for a lot of hand injuries, wrist injuries, elbow injuries, very, very common, as well, strokes, or other kinds of weakness.
Okay.
And so when you'd come in to see us in the Occupational Therapy Clinic over in Hunter's Crossing, we're in the T level across from the conference center.
Right.
We start with an evaluation.
Okay.
So that's going to take about an hour to an hour and a half, and we'll take a look and see what's going on. You know, what's your grip strength? What's your pinch strength? What's your movement like?
Okay.
What's your arm strength like? And where are you having trouble? Are you having trouble, you know, putting on a sweater? Are you having trouble feeding yourself?
All right.
All of the different functional aspects. So a lot of interview and a lot of having you try different things to see where the deficits are at the moment. If we find that you have things we can work on that we think we can improve, then we would continue to set up a treatment plan. Usually we see patients anywhere between 1 to 3 times a week.
Okay.
After the initial eval, if they need occupational
And is
therapy.
that for an hour or?
Closer to 45 minutes, but
Okay.
it can, depending on what the need is and how much we need to work on. It might be a little bit less, it might be a little bit more.
Okay.
Sometimes we have people that we're treating for 2 hands at the same time. They might have carpal tunnel in both hands or really bad arthritis in both hands. And so we might take a little bit longer because we have to address two
Certainly.
separate hands.
Certainly.
So it just depends on what the issue is. But about 45 minutes, anywhere I would say between 30 minutes to an hour.
Can I self-refer, or do I need to see a physician to get an order to come and see you?
You definitely need a physician's order to come and see us. So we have to work under a physician's order. And we get orders from a lot of different physicians, many from the medical center, from the doctors there, but as well from outside physicians that are primary care, urologists, orthopedists, orthopedic surgeons, rheumatologists. So any of those physicians can send you a prescription for occupational therapy, and then you would bring that down to us in the outpatient department and schedule your evaluation.
Okay. So I could see anybody on the outside get the order.
Correct.
And they can mail it in to you or
They can
fax
fax
or?
it to us, or you can walk it over yourself.
Okay.
Any of those would work.
All right.
And then we would schedule from there. One thing I do want to mention is we have to see you within 30 days of the date of the prescription. So if you know you're going on vacation for 3 weeks,
Right.
it might not be the best time to get the prescription. Wait till you come back, get it at that time, and then we can schedule it.
Do you see people upon initial injury, or do you see them after a period of time? Or?
Depends on what the doctor wants us to do. So if you're going to be casted for a while, let's say somebody broke their wrist and is in a cast, usually we're not getting involved just yet. The doctor wants you to be immobilized for a few weeks, and then once they start to feel like you can do some motion, then they would send it to us.
Okay.
And we might have different limitations. So they might send you to us and say, you know, we can do motion, but we can't do any strengthening right now.
Okay.
And so that's where we start until they feel like you're ready to keep going. So it depends on what the injury is.
And so what I'm hearing you say, you evaluate as you're treating.
We do, and we reevaluate. So every 10th visit, we always reevaluate, take new measurements, and see how you're doing. You know, is what we're doing working? Are you getting stronger? Are you getting more motion, or not? Do we need to change up the treatment plan? And then every so often, either when there's a new prescription from the doctor or any kind of a change, then we would reevaluate as well to incorporate that change.
Do you keep the physician informed? Do you send them evaluation information, I mean, of what you've gained?
Yes, so we send the evaluation gets sent out to the physician. They kind of sign off on our plan of care. So are saying that we think that somebody needs occupational therapy and we'd like to see them for this long.
Right.
So we absolutely do, as well with discharge or with any update along the way. If we have to update the treatment plan, then that as well would go to the physician for information. When we do a home safety assessment, a lot of times we also keep families involved, because a lot of times we might have a daughter or son or somebody else who's going to be purchasing equipment for that person. So we might also keep them in the loop and make recommendations of what item we are recommending for that person.
Medicare covers occupational therapy, right?
Correct. So in the outpatient department, it's under Medicare B benefits.
Okay.
That you would be coming and visiting us.
Do I have a limited number of visits I can do within a year?
Not a limited number of visits, but you actually have a limited amount of money.
Oh, okay.
Medicare gives a pool of money for occupational therapy for the calendar year. Now, once you've used up that pool of money, there are some exceptions to be able to have more. For example, a different diagnosis.
Oh, okay.
So if somebody breaks a wrist in January and we end up seeing them for a few months, and unfortunately, 3 months down the road they have a stroke.
Right.
Different diagnosis, different situation, so we can get an exception to that.
So someone shouldn't just say, well, I've already done occupational therapy, I can't go back again, right?
Correct. You can always come and check with us. We can always take a look and see how much you've done in that calendar year already, and if there's any concern about doing more or not at that point.
Let's say I've gotten my brace off and I've gone to occupational therapy. Do I just rely on the fact I did an hour's worth with you and not need to worry about anything else that week?
No. So most of what we're going to do is we're going to send you home with some homework.
Okay.
You're going to have a home exercise program you're going to need to follow up as well at home. And the idea is to get you to a point where you can do this on your own, where once we are just sort of progressing along and you've gotten to where you need to be, you can continue with the exercises at home, with the putty or with movement or whatever it is, or if we're seeing you more for dressing, that kind of thing, with the giving you the recommendations for the adaptive equipment that's going to work for you. Okay. So no, you'll have to do some work at home as well.
Can't get off that lightly, right? With all of this, how does it tie in with my overall health care?
Well, it's important to try to maintain your function as long as possible, and keep yourself as independent as possible for as much as you can. So sometimes people take for granted little things, like having a finger that's stuck and that won't work, and all of a sudden my hand is getting tighter and more painful, but let me ignore it because I've got other things that I need to worry about. But what happens is down the line it becomes a secondary problem, and now you can't get your shirt on, or you can't get your jacket on, and now it starts evolving into something else and you need more help at home. Okay. So it's important not to ignore some of the smaller things, and try to get them head on when you can.
Okay. How can I get the greatest benefit out of going to occupational therapy?
I would say first get the prescription, come down, and I ask a lot of questions. Come with a good list of, this is what I'm having trouble with, I'm really struggling with this and this and this, and ask a lot of questions when you come. Ask for a lot of input. We're happy to answer and work on them. And sometimes we've been seeing somebody, we know that these are an issue, but we've never asked about something else, and then all of a sudden it comes up like 5 sessions in, and we could address it from the beginning.
Sure.
So come with your list of, this is everything I'm having an issue with, and let's see what we can improve.
Sounds great. Well, Michele, thank you so very much for coming this morning and talking to us about occupational therapy. And for all of us who need you, hope we get down and see you soon.
Thank you. Happy to see you.
Thank you. Come back.